brain death or brain stem death. The core concept, what is brain death? Brain death is irreversible loss of the whole brain function. Okay, with the irreversible loss of the consciousness and loss of the capacity to breathe. ठीक है, ब्रेन स्टेम कोई काम नहीं करता है, पेशेंट का कॉन्शियसनेस ज़ीरो हो जाता है एंड ब्रीदिंग कैपेसिटी भी लॉस हो जाती है, दैट इज़ कॉल्ड ब्रेन स्टेम डेथ। वही परसिस्टेंट वेजिटेटिव स्टेट एक अलग चीज़ है जिसमें कॉर्टिकल फंक्शन सीज होता है, ब्रेन स्टेम इंटेक्ट रहता है। तो जब तुम ईईजी करते हो तो फ्लैट ईईजी आता है, ठीक है, तो इसको सेरिब्रल डेथ बोलते हैं, इसको परसिस्टेंट वेजिटेटिव स्टेट बोलते हैं, दिस इज नॉट ब्रेन स्टेम डेथ। ओके, नाउ व्हाट आर द एनाटॉमिकल एरियाज एंड द फंक्शन दैट इज इन्वॉल्व इन द ब्रेन स्टेम डेथ? फर्स्ट इज द असेंडिंग रेटिकुलर एक्टिवेटिंग सिस्टम, ठीक है, दैट इज फॉर द वैकफुलनेस, this area is responsible for the wakefulness. Now loss of this function causes the persistent uh, a loss of the consciousness. Now primary respiratory center, that is in the medulla and the reticular core, so patient cannot breathe. Circulatory center, as we all know, nucleus tractus solitarius, which is responsible for the all the cardiac reflexes as well as the autonomic reflexes, that is lost. So circulatory center function is also lost. Then the thermoregulatory center, which is in the hypothalamus, is also lost. So there can be the hyperthermia or the hypothermia. Now pituitary gland function is also lost, endocrine control is lost, there may be the uh, endocrine dysfunction. Then CNS immune control, the cytokines, ICAM and the VCAM can be altered in the circulation, immune control. Now what are the prerequisite for the diagnosis, how we can diagnose the brain stem death? There should be clinical or the neurological evidence of the acute CNS catastrophe. It is not like that कि nothing, patient चलता फिरता है, कुछ नहीं हुआ और अचानक से patient brain stem death हो गया, ऐसा नहीं होता है. So there should be some clinical evidence for the acute CNS catastrophe, like head injury हुआ है और अंदर एन्यूरिज्म बस्ट हो गया है, एक्सट्राड्यूरल हेमरेज है, इंटरवेंट्रिकुलर हेमरेज है, some injuries है, tumors है, anything, some catastrophic evidence should be there, and that should be some neuro imaging finding for that, either the CT or the MRI or the contrast studies like that. Okay, now and there are you should exclude the complicating causes like electrolyte imbalance, acid base disorder, endocrine disorder, drug intoxication or poisoning. This should be excluded. These are the complicating cause which can mimic the scenario like brainstem death. So this thing interfere with the diagnosis of the brainstem death. So you should ensure that this thing are the normal and this are not present while you are diagnosing a patient with the brainstem death. Okay, and the core temperature should be more than 32 degrees Celsius to 90 degree Fahrenheit. Patient should not be in hypothermia, because hypothermia also can mimic the same state like the brainstem death. Now you should do the two examination in the with the 6 hour apart. Two examination is mandatory. And who can examine or who can diagnose the brainstem death? So at least 2 to 3 independent physician of the transplant team. 2 to 3 physicians required, and this physician should not be part of the transplant team. So the idea is that कि अगर तुम पूरा ही transplant team को diagnose कर दे दो तो transplant team have bias towards declaring the patient as brain dead to retrieve the organs. So to remove that bias, they have told that 2 to 3 independent physician of the transplant team is required to make the diagnosis of the brainstem death. And out of this 2 3 independent physician, at least one should be either neurologist or the neurosurgeon or the anesthetist or critical care physician. Now, what are the clinical sign of the brainstem death? GCS will be 3 out of 50. Okay, there will be no movement on the pain or the pressure, but some movement will be there. That movement is called the Lazarus sign or the reflex. This is the brainstem. This is the spinal reflex. See, in brainstem reflex, above C2 level, the function is lost, but the below C2 level, the function is intact. This is the spinal reflexes. So, if you make any incision or if you apply some pain, there will be some reflexes on the hand or the shoulders or the leg. These are the spinal reflexes, and you should not consider this movement as a sign of the brain life. This is the most important, and the most people who is not aware of this Lazarus sign or reflexes consider this moment as a sign of the brain life, and even the patient is the brain dead, they declares that the patient is not brain dead. So this is the most important sign, Lazarus sign. Now brainstem reflexes, this is the most important part and the pillar of the diagnosis of the brainstem death. So before conducting the apnea test, you should carry out this brainstem reflexes. Pupillary reflex and corneal reflex should be absent. Ocular reflexes like oculocephalic reflex, which is we called doll's eye movement, should be absent. Then the caloric test, you put the hot and cold water into eye and look for the nystagmus. There should be no response. Then the facial reflexes like the jaw and grimace, pain reflexes, that should be absent. Then the pharyngeal reflexes, gag reflex should be absent. How will you check the gag reflex? The patient will definitely be on the ventilator. There are the higher chance that the ET tube is in the C2, and you move the ET tube, or you insert the yanker in the with the suction catheter to the pharynx, stimulate the pharynx and observe for the gag reflex. The gag reflex should be absent. Now the tracheal reflex, no cough on the suction. You insert the suction catheter through the ET tube into the trachea, and there should be no cough or the no any reflex. Now apnea test. How will you conduct the apnea test? Okay, so before conducting the apnea test, you should compulsorily go through all these clinical findings, and your brainstem reflexes should be absent. If anything is present, if any reflex is positive, you should not go for the apnea test. Patient is not brainstem death. If all these criteria meets, then and then you proceed for the apnea test. Okay, so prerequisite of the apnea test is all the brainstem reflexes should be absent. Then hemodynamics should be stable. There should not be hemodynamic instability. Core temperature should be more than 32 degrees Celsius. Patient should not be in the hypothermia. Now you pre-oxygenate with the 100% oxygen for 10 to 20 minutes. Okay, and you do an ABG. In this ABG, before starting the apnea test, your PaCO2 should be normal, 35 to 45, and PaO2 should be more than 200 mmHg. Then you proceed for the apnea test, and you exclude the complication. Like you ensure that no neuromuscular blocker is given, no sedative agent has been given. Okay, then you proceed for the apnea test. Now how will you do the apnea test? You Patient will be definitely on the ventilator. Patient will be on the ventilator. ET tube will be in C2. Now you disconnect from the ventilator after giving this 10 to 20 minutes of the 100% oxygen through the ventilator. You disconnect from the ventilator. You administer the oxygen via catheter into the ET tube with the 6 to 10 liter per minute. So you just administer only oxygen, 100% oxygen with 6 to 10 liter per minute via a catheter inserted into the ET tube till into the trachea. So some physician just connect the oxygen in the ET tube. That is also valid. But the 6 to 10 liter flow of the oxygen, 100% oxygen is must. Now, what to observe? Now, monitor for any respiratory effort, like closely monitor. You connect the ETCO2. ETCO2 monitoring should be connected. Waveform monitoring. ETCO2 waveform monitoring should be connected. You look for this waveform, if any waveform is there or not. And look for the clinically chest movement or the abdominal breathing movement. Okay. Now, if any cardiac instability is found, like arrhythmia develops, hypotension develop, abr- you immediately stop the apnea test and restart the mechanical ventilation. Okay, so you have done a ABG prior at the starting of the apnea test, and after 8 to 10 minutes, you again do ABG, second ABG. Okay, now in second ABG, what will you see? In second ABG, you will see that if the PaCO2, what is the PaCO2? So the starting PaCO2 is 35 to 45 mmHg, we all know. If the post apnea, after 8 to 10 minutes, the PaCO2 is more than 60 mmHg, your apnea test is positive. That means the patient is brain dead. Apart from this, there should be no any respiratory effort. There should not be any movement on the patient. PaCO2 should be more than 60 mg, or the rate of increase of the carbon dioxide should be 2 to 3 mmHg in first minute, in first minute, and then 1 to 2 mmHg per minute thereafter. So approximately in 10 minutes, CO2 should rise by 20 mmHg. So if the starting is 40 mmHg, the end point is 60 mmHg. So if such amount of the PaCO2 has rise, then the brain death is confirmed. And the pH, post apnea pH, should be less than 7.25 after 10 minutes. When apnea test is negative, that shows the patient is not brain dead. If you find any respiratory effort is observed, if the post apnea PaCO2 level is below 60, you should not declare the patient as a brain dead. There should be some alternate cause apart from the brain dead should be evaluated for. When you will stop it, stop the apnea test, if you will find a significant arrhythmia when you are when the patient is disconnected, or you find the significant hypotension is there, you immediately stop the apnea test and reconnect on the ventilator. What are the special consider? If the test is negative, you re-evaluate and consider for the other confirmatory test. Now, there are some difference between the adult and pediatric patient in evaluation of the brainstem death. See, for adult, we have discussed all the things that is for the adult. Now, what is for the pediatric patient? The larger observation period is required. In adult patient, we have carried out the two apnea tests, 6 hours apart. While in pediatric patient, it is 24 hour or the 12 hour according to the age group. So two complete examination at a specific time interval like 24 hour, or in for the newborn it is 24 hour apart, or for the older children it is 12 to 24 hour apart. Now for the pediatric population, we less rely on the clinical examination and more rely on the serial imaging. There are more stringent parameters for the hemodynamics and the metabolic stability. Rest everything is same for the pediatric patient. Like, for if the patient is the premature, the two examination 24 to 48 hours apart is required. For the neonate less than 1 month, 12 to 24 apart two examination is required. For 1 to 12 month of the child, 12 to 24 hour apart two test is required. For 1 to 5 year of the child, 10 to 28 hours apart, two examination is required. Rest all is same for the pediatric patient